Assalamu alaikum, sabah al-khair, good morning. My name is Ibrahim Sbeih. I'm talking to you from Farah Health Care Campus in Amman, Jordan, and I'm going to present a case of toxoplasmosis of a spinal cord presenting as a spinal tumor in AIDS HIV positive patients. By the way, this is the black iris, which is the symbol of Jordan. It only grows in Jordan. The theme, as usual, is the clinical, radiological, operative, and pathological correlation. And this case is very, very unique because it is very, very infrequent cause of spinal cord disease and may or may not be associated with the brain toxoplasmosis. So you are facing a very rare situation. The data of this patient is 35-year-old male from Syria. He works as a clerk in a judicial court in Damascus. No history of alcohol ingestion or drug abuse. He's a heavy smoker with no known allergies. He's married with 2 children. His story goes back to 18 months before presentation with upper and lower limb weakness and some bladder symptoms, retention of urine intermittently, chronic constipation, and abdominal pain. Nothing in his past medical history. Vital signs were normal. His general examination was peculiar in that he was cachectic. It's something like 37 kilograms for this male adult patient. And his chest showed some hysteresis that disappeared on cuffing. Glasgow Coma scale was 15/15 with normal mental state. He had weakness in his limbs, right and left, grade 4/5. There was a sensor level on his trunk at T4. Reflexes were brisk. And again in his lower limbs, weakness more on the left side, pyramidal weakness, brisk reflexes, and outgoing plantar responses. Just to remind you about the sensory level, nipple is at T5. Some people consider it as T4. It's just the same. The level is about there, and one has to appreciate this sensory level from different kinds of sensory levels or dissociated sensory loss in various diseases, whether it is peripheral nerves or core disease or whatever. The CBC showed low hemoglobin. Platelets were increased, and his white PC differential was okay. Blood film showed a macrocytic normochromic with anisocytosis. His urea was elevated, his creatinine was elevated, and his potassium was elevated. Chest X-ray showed basal infiltration, and the ECG was normal. He brought some images with him from Syria, and he refused that we repeat them here, so I'm showing you the images from Syria. They're not a very good quality, but the patient insisted that we don't repeat them because they were rather recent. This is the cervical spinal cord, T1 before contrast, and this is T1 after contrast. For all intentions and purposes, this looks like a tumor. Again here. And this is T2. You can see the changes, extensive changes, in addition to the enhancing lesion here. So enhancing lesion here and then lots of changes here. Please. Same thing. T2, you can see the extensive changes, the enhancing lesion and the extensive changes there, intramedullary. Again in the lateral and EP views. And this is the axial cut, and you can see the lesion inside. Again here. And in T2 you can see the region intramedullary. So what's the differential diagnosis of such a lesion? The comment that comes to your mind is ependymoma and astrocytoma. And whenever you say a lesion is ependymoma, it tends to be an astrocytoma. So you cannot differentiate in spite of everything. Subependymoma, oligodendroglioma, intelligent cyst. Again, this was one of my patients from here, from Jordan. Epidermoid lipoma, epidermoid and lipoma. Intramedullary schwannoma. This is true intramedullary schwannoma, which is very rare. A patient from Libya. Ganglion neuroma, ocytoma, hemangioblastoma, cavernoma from this lady from Arab Emirates. MS. MS can come with the plaques like this, that looks like tumor, tuberculoma in a doctor, Jordanian doctor, primary. And of course the lymphoma, which is the forgotten disease. They can come up with masses like this. Transverse myelitis of lupus erythematosus. Look at this mass, just look like a tumor. AVM, we forget about AVM, spinal AVMs. Radiation-induced myelopathy. Our radiation oncologist may not like it, but this is a complication of radiation. And this patient had a CA esophagus, and D3 was treated with radiation. This is the central area of radiation, causing radiation-induced changes. Vascular myelopathy, do whatever vascular disease you have. And again, the forgotten disease, the subacute combined degeneration of the spinal cord due to vitamin B12 deficiency. It affects the dorsal column, gracile and cunate. So the differential diagnosis is really wide, and sometimes you need something to help you to differentiate, and here comes the effect of PET scan. In this case, in transverse myelitis, it does not glow. In tumor, it will glow. So PET scan can help to differentiate. But I tell you, in my practice, I was never able to define the pathology beforehand. So we did a few consultations. Dr. Muhammad Shahab, are you around? Dr. Muhammad Shahab, neurologist. At that time, he saw the patient. He has a quadriparesis, he has sensory level, and there is a spinal lesion which we don't know what is the nature of it. And we called Dr. Man al-Hadidi, again he's not around. The man is a nephrologist, so he said this patient has impaired kidney functions, as you have seen, hyperkalemia, so he diagnosed acute renal failure, put for this catheter, give 500 cc normal saline, Lasix, and then repeat the kidney function tests with ultrasound. Indeed, abdominal ultrasound showed overfilling of the pelvic ileal right kidney due to distal obstruction, and repeating the kidney function test showed things coming back from the previous high values. General surgeon was also consulted to verify the story because of the chronic abdominal pain and constipation. He found diffuse abdominal pain and tenderness, but for him this was just constipation, nothing to worry about. Again, we are talking about the global approach, the holistic approach for the patient. The anesthetist put him in American Society of Anesthesia grade 4. Let's look at some of the anatomy that we are going to face during the surgery. Most importantly is the blood supply of the spinal cord. Blood supply of the spinal cord comes around the surface of the cord, and from there you get these branches going in. So this area is very weak in its blood supply. So central area of the cord is very vulnerable to any vascular changes. And this circuit of vessels around the cord comes from different arteries, mainly radicular arteries coming from the anterospinal, posterior-spinal, the branches from the vertebral artery, the lumbar branches, aorta, etc. So this is the cut section, and again you can see the artery going and forming a circle or a circuit around the cord, and the branch is going in. So here is a good blood supply, here is a poor blood supply. So anything can affect the cord. Again, the cord and the blood vessels go into it. Again, we have to remember the cross-section of the spinal cord. We have the anterior sulcus and the posterior sulcus. And people speaking about myelotomy. There's no myelotomy. We should not cut through the cord. So this is a sulcus and there is a posterior sulcus. So we open the posterior sulcus. The gracile and the cunate for the joint position sense. The corticospinal tract, the lateral and the anterior. The spinothalamic tract, the lateral and the anterior. And we have to remember the presentation and the gracile and the cunate. Sacrum is medial, cervical is lateral. While this is opposite in the corticospinal tract and the spinothalamic tract. Cervical is in, sacrum is out. As you can see here, sacrum is medial, cervical is lateral, and the corticospinal tract is different. So some surgical tips here. In the cervical lesions, I'd like to put the patient in the sitting position. And there is a question about giving methylprednisolone. We used to give it in the past. Nowadays, because of the controversy about it, we stopped using it. In fact, the use of steroids in head injuries and spinal injuries has stopped now. There is a practice which is wrong, and we have to clarify it. Take a biopsy and send for radiotherapy. This should be condemned, not by me, by every single spinal surgeon in the world. The idea of opening it, taking a small specimen, and convince the histopathologist that, oh, this is ependymoma or astrocytoma and give radiotherapy is something criminal and should be condemned. And when you do myelotomy or opening of the sulcus, you open it over the whole extent of the tumor because you want to excise the tumor, not to take a biopsy. And you do laminectomy, one vertebra above, one vertebra below. In children, we do laminoplasty. How to open the dura? So here is various surgeries showing you how to open the dura. Of course, we have done the laminectomy, and here we are opening it using both hands. You can open it this way, you can open it this way, you can open it with scissors. So the dura is opened like this. And then we come to the arachnoid. We try always to open the dura alone, separate from the arachnoid, to save lots of CSF loss, especially sudden one. So here is the arachnoid. And we maintain the arachnoid as a separate membrane so that we'll suture it again when we close. So we are opening the arachnoid. So arachnoid is a different layer which you open it away from the dura, separate from the dura, and you have to close it after that. And once we open the dura and the arachnoid, we will come to the intradural lesion. This is the spinal cord. This is hemeningioma, which is intradural but extramedullary. It is not inside the cord, but it is inside the dura. So you deal with that pathology. And when you do intramedullary, you have to know where to open the posterior sulcus. So you have to identify it using the arachnoid knife, and you open the sulcus. So we stop talking about myelotomy. We speak about opening of the posterior sulcus. And once we finish, we close. Different cases showing you the closure of the dura and the arachnoid. Here we are taking the arachnoid, putting it with the dura, and you close it together. This will prevent adhesions. It will ensure no CSF leak And I always close using silk, so that if I need to go back again, the black color of the silk will guide me. Again, this is a microscopic surgery, not to be done with the naked eye. Okay, I'll show you some of the snapshots of the surgery, of our case, of our patient. Here we're opening the dura, and this is the cord. This is the dilated cord. Look, here is the normal size of the cord, and here is really dilated. And then you look at this artery, it is smack in the center. It is in the sulcus, and you have to open the sulcus on one side of it. Don't cross it, do not coagulate it, just go to one side and you'll find the sulcus. And here the cord is open, and we are inside the cord taking the pathology out. Intramedullary. So let's see the surgery. Here's the dura is opened. Here's the arachnoid is opened. We don't open the two together. Here is the dilated cord. This is a normal cord. We suture the dura and arachnoid to the surrounding tissues so that we open it like a book. And we are now looking to identify the central sulcus and open this sulcus. So here we open it. We know exactly we are in the midline because we can see the vessels going inside. And this is obvious lesion, different from the cord substance. We're trying to find a plane of cleavage, which we were able to. There it is. This is a tumor and this is a cord. White color of the cord, and this is the tumor.
It comes right off, huh?
Yes. Sometimes you find a plane of cleavage, sometimes you don't. But what happens is that if you have the practice of just going for a biopsy, you just go snatch a small piece and send it. That's the end of the surgery, which is not good. And we have done a good myelotomy, or opening of the posterior sulcus. So this is abnormal tissue. The feel of it, the sucker on it, the consistency is abnormal. And it has a plane of cleavage with the cord. Of course, here we send a frozen section to Dr. Opportunistic at that time, and we continue doing the surgery. It takes about 45 minutes to 1 hour to get the answer, during which I continued taking the tumor out until the answer. Dr. Opportunistic was on the phone, so they put the phone in my ear. Yes, what's the diagnosis? He said, oh, this is a parasite. I said, what? This is a tumor. She said, no, there is a parasite. What kind of parasite? I said, don't know. We look at it, but it is not kind of the tumor that you are thinking of. So I continued taking whatever I could without damaging the patient. This is pathology, Dr. Opportunistic.
Assalamu alaikum. Actually, this is very interesting case, because when the neurosurgeon expects a tumor and you give him a parasite which you suspect that could be toxoplasm, it was very much contradiction with the clinical diagnosis, and it really has to be you have a brave heart to do that in the frozen section, because frozen section usually is difficult. But usually, as a pathologist, I always give advice to my colleagues, junior pathologists, listen to your clinician, but don't make a diagnosis according to their wish, because you will make so many mistakes if you really listen to them without looking at your slides. Let's see what we saw. This is permanent section, not the frozen section, but you can see there is a lot. It's cellular, and to me these are inflammatory cells with histiocytes. But you look at this area, you look, there is a cystic space with some dots inside it. Next, see, you can see higher power. These dots are larger, and they really look like a parasite. It resembles on the frozen section to me Toxoplasma, but usually as a pathologist I learned not to say something that I have to retreat after that from my diagnosis. So I say the best and the most accurate at that time. So I say this is parasite, and we leave it to the permanent section to do further staining. You can see this another one area, and you can see many dots in here. Looks like parasites in a cystic space. Next slide. And this another one. So again, this is very high power oil immersion. You can see many dots of parasites. This actually the tachyzoids of Toxoplasma, or trophozoites of Toxoplasma in a cystic place. This again another tachyzoids of Toxoplasma. So I thought at the permanent, before we issue the report, next slide. Again here you can see them dots filling the cystic space and with inflammatory cells. Again here. This is another area, different areas of tachyzoids. This is high power of tachyzoids. We suspected very likely that this is Toxoplasma. So I told Dr. Ibrahim at the end, before we sign out the case, that looks to me morphology of Toxoplasma. We need to confirm it by two things. We have to do Toxoplasma IgG, IgM, but this is usually not a confirmation. But we need to have the antibody for Toxoplasma immunohistochemistry, and we don't have it in our lab now. It will take up to 2 months till we receive it when we order it. He said, take your time, because we need to really confirm it 100%. And I told him to really check for HIV status of this patient, because it was not known at that time. And you can see the immune staining when we had the immune staining 2 months after this operation. We strongly positive. The brown staining means it's positive. Strongly positive for Toxoplasma, and you can see here it's very strongly positive for Toxoplasma parasite, and again here. So this was a case of toxoplasmosis proved by immunohistochemistry, and of course you will tell you that Dr. Ibrahim will tell you that the patient turned out to be HIV positive.
So it really needs a brave heart, as you said, to get to that, because in the theater I said, what? Parasite? This is a tumor. So I asked for freedom, like in the movie. So patient woke up fully conscious on the table, and the following day we did post-operative cervical MRI. You can see the post-operative changes, and you can see that we were here inside the cord. Again, that's immediate. The following day cervical MRI. And this is the site where we got into the cord. The opening of the posterior sulcus, or so-called myelotomy, which has been, deleted from literature. We don't no more speak about myelotomy. We speak about opening of the posterior sulcus between gracile, cunate here, gracile and cunate there. There, and there. So because of the issue that was raised that this is a parasite and most likely toxoplasmosis, we said, well, we'll go for a brain MRI. And behold, this is there. Multiple lesions. There in the basal ganglia. Multiple. So we knew that this is correct diagnosis. We continued taking care of the patient. He improved gradually, and we discharged him on the 9th post-operative day. Remember, he's Syrian, and he wanted to go back to Syria. And we have some problems to solve. So I'll ask Dr. Muntasar Balbisi to come over here and tell you about it.
Thank you, Dr. Ibrahim. Good morning. Thank you all for coming and attending. My name is Muntasar Bilbesi. I'm an infectious disease physician. Thank you. And thank you for allowing me to be part of this CME, which according to Dr. Glasser, you learn the most by teaching. So, Toxoplasma gondii is just a simple unicellular protozoa like amoeba. This particular protozoa lives in cats, okay? The oocysts are discharged with the cat feces, which then contaminate vegetation, soil, and maybe then eaten or ingested, let's just say, by animals or man. So when man ingests them, or woman for that purpose, they get toxoplasma, the bradyzoids invade the intestinal epithelium, and then they disseminate through the bloodstream throughout, to the brain and everywhere else. Most of the primary toxoplasma infections are actually asymptomatic. And when they do manifest clinically, most of the time it's a matter of an acute mono-like syndrome with fever, cervical lymphadenopathy, perhaps some splenomegaly, and it's typically a self-limited disease in the immune-competent patient. Ingesting the meat, the uncooked or poorly cooked meat of animals that have ingested cat feces can lead to the transmission of the disease. Okay? So that's one of the most common ways of transmission. Other ways of transmission are through a blood transfusion from a patient with active toxo, through the transplant of an organ, for example, the heart, from a donor that had toxoplasmosis, and I'll show you an example of that. And of course, let's not forget that if a pregnant lady happens to ingest it and develop active toxoplasmosis while pregnant, the oocysts can go to the baby and cause a severe malformation or number of malformations, including congenital toxoplasmosis with hydrocephalus and problems with vision, chorioretinitis, obviously a sad situation. So we kind of went through this. The immune, and after that, the body's immunity controls it. And unless and until a person is so immune compromised that toxoplasma can reactivate, for example, an HIV patient. And among HIV patients, there's a 30% chance of reactivation if that person is HIV positive, toxoplasma positive with the antibodies, as well as not being treated for HIV and not being on prophylaxis. CNS is the most common site of reactivation, as you can see. Cerebral, in this study of 1,700 HIV positive patients, 166 cases of toxoplasmosis, almost 90% reactivation in the brain. It's quite rare and somewhat unheard of to have that reactivation in the spinal cord. As in our patient, there was evidence later on of cerebral reactivation and abscesses. Pulmonary in 6%, ocular 3.5%, and disseminated in 1.5%. And that's what it looks on the retina, acute macular retinitis over here. And this is the terrible scar of toxoplasmosis in a congenital case. This is actually a patient that I saw last month, a youngish guy, 15 years old, with cardiomyopathy, underwent cardiac transplantation in India, and he received toxoplasmosis and PCP prophylaxis for 3 months, and after stopping it, came down with fever and dry cough and evidence of pneumonia, and he had toxoplasma pneumonia. In AIDS patients, usually are multiple, but you see solitary or multiple ring-enhancing brain lesions, and Dr. Hussam explained the pathology so nicely, so I don't have to go through that. Now, our patient clinically speaking, there were multiple hints that this was a severely immunocompromised patient. He was cachectic. 35-year-old was his weight. He had lost a lot of weight. By history, he had a reactivation of herpes zoster 3 months prior. And that doesn't happen in the younger people except if you have a severe immunocompromising illness, HIV, lymphoma, right? So that was a clue that this was an immunocompromised patient. So we had ordered, perhaps pre-op even, HIV serology and toxoplasma serology, and he turned out to be positive. That was not surprising on the clinical side of things. We also did HIV viral load for this man, and his viral load was 2 million. 2 million copies per ml. It's the highest I've ever seen. The world record is held at 1 billion copies in a ml, if you can fit that many in a ml. So yeah, so this was a very, very active HIV case. Now, as you know, HIV infects and depletes the body's supply of CD4 T lymphocytes. Normally, you'd expect 1,000 per ml. This guy had 6. When a person is, CD4 is less than 200, they're considered severe enough to have opportunistic infections. His was 6. So this was very, very advanced. Okay? This guy probably had less than 3 months to live. All right? Just to show you on the survival curves, he had the lowest. So his CD4 was on this curve, less than 50, and his HIV viral load was over on this pink line, way above 200,000 copies per ml. So he was in danger of losing his life. So as Dr. Maurice knows, when we see these patients, we can go for PCR on the CSF, a very useful modality to diagnose it. It can be done on the tissues. It can be done on other fluids like the BAL in that pneumonia patient. It can be done on the vitreous and aqueous fluid by the ophthalmologist. Amniotic fluid in OB and Gynae, you suspect congenital toxoplasma, you get some amniotic fluid and do a PCR. And PCR is highly specific in the CSF with variable sensitivities, and the pathologists are always happy splicing DNA. In fact, they're happy splicing anything, really. So this guy, in short, had toxoplasmosis with advanced HIV, and typically treatment of toxoplasma in the immunocompromised patient starts with an induction phase, then a maintenance phase. In the immunocompetent, it is rare that we have to treat toxoplasmosis. But in this guy, we had to treat it. So the mass in the spinal cord had been removed. Still, he had some stuff in his brain that needed treatment. And then we needed to address his HIV situation. The preferred treatment for toxoplasmosis is pyrimethamine plus sulfadiazine and leucovorin. Alternatives are pyrimethamine, clindamycin, pyrimethamine, atuvacone, leucovorin, and trimethoprim sulfa. Unfortunately, pyrimethamine is really hard to find. We have some at King Hussein Cancer Center, but in the rest of the country, we really are very hard pressed to find it. The duration of therapy typically is an induction of 6 weeks, then lifelong prophylaxis, or if you can treat the immune deficiency and get the CD4 over 200, then you can stop the prophylaxis. And so our patient who denied let's say, unprotected sexual exposure or blood transfusion, had not had a transplant, and so he was HIV positive, and it's immaterial to us where he got it from. His wife was luckily negative. Am I going back? And he had a high titer of HIV, of toxo IgG, and this shows you the viral load. We kind of went through all of this. His HIV had also probably caused his renal problems. He probably had HIV nephropathy. So we treated him with cotrimoxazole, okay? Cotrimoxazole, trimethoprim sulfa, and we started antiretroviral treatment. You would be surprised that nowadays, perhaps you wouldn't be, but some people are. We have a lot of treatments for HIV. It has become a treatable disease, not a curable disease, a treatable disease, a chronic treatable disease like diabetes or hypertension or MS. And so we treated this patient with Combivir, which is a combination of two HIV drugs, AZT and 3TC, plus Kaletra, leponavir with ritonavir. We gave him Bactrim Fort and Daraprim and clindamycin, which has some effect on toxoplasmosis. 6 weeks, he did very well. He was discharged in a stable situation from the hospital. At 6 months of follow-up, his viral load, which had been 2 million, was down to 7,600. Okay, the viral CD4 count, the cells that defend the body, if they are less than 200, you get opportunistic infections. Went up to 76, then 196, then 238. So we were able to stop secondary prophylaxis when he had become immune competent again, if you like. His weight increased from 37 to 53 kilos. And we always teach an HIV patient, we don't take away their pets because they need that support, but we always teach them to avoid being exposed to an infection. So if they deal with cat litter, they have to wash their hands or wear gloves. They work in the garden, same thing, and to cook the meat all the way through, wash and peel veggies and utensils. And to remind you, CDC considers toxoplasma a leading cause of death from foodborne illness in the United States and worldwide. And so for cat lovers, and I'm one of them, but if you're a cat lover, you should be aware that cat-related infections include, so toxoplasma we talked about, other things, Pasteurella multicida in cat bites, Bartonella hensleyi, which is known causes cat scratch disease, and in HIV patients can cause other problems, Salmonella, protozoa such as Toxo, but also Cryptosporidium parvum and Giardia lamblia, and then the parasites of Toxocara canis, the visceral larva migrans, and Ankylostoma, the cutaneous larva migrans, which enters the skin of people who walk on beaches barefoot and then have to be removed. I'll leave you with this final thought. The HIV medications have made a revolution in this HIV epidemic. And since about 2000, you can see where curves started to change direction here in 2002. New cases started getting less. People living with HIV started living longer, so there are more of them. And AIDS-related deaths globally went down. So we are now able to treat every single HIV patient, and no HIV patient needs to die of a previously fatal disease. We can treat all of them. So you get one, please refer them. And I'll stop here and let you figure this one out for yourselves. Thank you.
Okay. So you have seen this gentleman from Syria, 35-year-old, very benign looking. He's a clerk in the court. He's married with 2 children. So when I got the news that this is HIV positive, I sat with him. I said, man, let's talk freely, open up please. You are married, do you have any sexual relation with anybody? No. من هالناح من هون إلى هناك ما فيش. He denied it completely. So that's what we do. We ask our patients and we sometimes believe them wrongly. If he says, I did not have sexual relations, I did not go, I did not travel, we say, did not have sexual relations outside his marriage, he did not travel, he does not have pets at home, etc. That he is clear. That shows you that this is serious. So cat lovers, take care. I was one of them. I had 3 cats at home. After that, I sent them to the Saudi embassy. So 6 months from surgery, his HIV was negative. Listen, this is 6 months. This is a patient who was going to die in 3 months' time. Again, the CDR raised, so this is a very good response. And we did a follow-up 1 year after, 1 year. And here it is. Now I'll tell you a story. How did we do a follow-up? We went back to Syria. And the security situation in Syria and the war, we could not get in touch with him. So I sent one of my staff, a doctor, junior doctor. He traveled to Syria. He went to his house and convinced them to have an MRI. And we paid for the MRI because he could not pay. We wanted to know what's going on. So you can see his cord is a little bit atrophic, of course, from the disease, but he is kicking and working like nobody. So no lesion whatsoever. These are cut sections of his cord, axial cuts, no tumor, and as I said, no HIV. And his brain lesions disappeared completely. This is 2.5 years. So we diagnosed him correctly and we treated him correctly. HIV positive, and the IDS is treatable but not curable, but is treatable. And because it is a rare case, we published it. This was published 2016 in Insights in Neurosurgery, and this is myself, these are my residents. So for a resident to publish a paper in the first and second year is something. I asked the residents sitting in this room, have you published or tried to publish a report? Because if you want to go for training abroad, the first question you'll be asked in an interview, have you did any research or work? And if not, your interview will end there. This is the paper as it is. And we cited 12 references. So, quick overview of the CNS involvement in AIDS patients. 35% of all AIDS have these CNS lesions. And brain biopsy, so this is a study from Chicago, published in Journal of Clinical Studies, and they had 264 AIDS patients. They have done brain biopsy, and what did they find? Lymphoma, leukoencephalopathy, toxoplasmosis, and others. So primary CNS lymphoma can come up with various things, especially in immunocompromised patients. This is the cases and their counterparts of PETs, and primary CNS lymphoma can come up with various shapes, like masses, like tumors. So toxoplasmosis is the most common intracranial infection. It is very rare in the spine, but it is the commonest in the brain. Other lesions that can be caused by AIDS, HIV positive, is the encephalopathies, and our neurologists here are aware of it. Maurice, have you seen cases?
Autoimmune, yes.
Yes. Brain abscess, of course, because the immunity is compromised. Infarctions, HIV-associated dementia. So dementia, but it is HIV-related. Mycobacterium TB, any infection would just get hold of the patient because he is immunocompromised. This is TB. Let's go through the ophthalmology. Do we have ophthalmologists in the audience? Yes.
No.
Yes, there is. Nice. Let's see. Herpes zoster. Conjunctival squamous cell carcinoma. Ulcerative blepharitis. And look at this. Enhancement of the optic nerve with diffuse infiltration in his lungs and a spinal lesion. That was also an HIV patient. How many of us would think of this being caused by HIV? Vitritis, HIV retinal vasculopathy, hemorrhages, aneurysms, cotton wool, etc. This is called cotton wool. Retinal necrosis, infectious retinitis on top of the diseases, whether it is cytomegaloSME, cytomegalovirus, varicella, herpes, and toxoplasma, and these corresponding lesions. DSAMV retinitis, again Mycobacterium tuberculosis in the retina as a granuloma, and of course infection in the this is pneumocystis carinii in the eyes, in the choroid area. This is macular toxoplasmosis, and this is, as it says, this AIDS would cause increased risk of developing AMD, that is age-related macular degeneration. What about ENT? Herpes zoster, otitis externa, chronic one. It's called malignant otitis externa. Candidiasis, aftosalces, Bell's palsy. How many of us would think of Bell's palsy being caused by HIV? Serous otitis media, cervical lymphadenopathy, in this case it's tuberculosis, non-Hodgkin lymphoma, Kabuchi sarcoma. Kabuchi is the name of Christian Clark in Jerusalem that was arrested by the Jews. And I loved Kabuchi sarcoma because of him, because he was so patriotic. He defended Jerusalem in a big, big way as a Palestinian Christian. And we don't differentiate between Palestinian Christians and Muslim Christians. We are all Palestinians and we defend our country, as well as our country, Jordan. In the cardiopulmonary area, endocarditis and valve disease, pulmonary embolism and infarction, dilated cardiomyopathy, look at this diameter, coronary artery disease, being calcification or blockage, pericarditis and pericardial effusion, aortic aneurysm, pulmonary hypertension, non-Hodgkin lymphoma. In the musculoskeletal system, of course I'm just giving examples, not all the diseases, but tuberculosis spondylodiscitis developing in immunocompromised patients like this can come with cord compression, Burkitt's lymphoma in the psoas muscle, Epstein-Barr myopericytoma, osteomyelitis of the tibia and fibula, of course, avascular necrosis of the head of the femur, necrotizing fasciitis, septic arthritis, shoulder and knee. In the GI tract, there are lesions that contain the virus in the stomach, in the small intestine, and in the colon. And because we are in Farah Hospital, where it's a center for obs and gynae, we have to speak about pediatric HIV, AIDS. In developed countries, the number of children of HIV-positive mothers newly infected with HIV has dramatically decreased because of the care that we are giving to this disease. But listen to this, by the end of 2006, estimated 2.3 million children below 15 years of age are living with HIV, and we have about 500,000 infections occurring in children every year. So it's still very common. Look at this candidiasis in this boy, or this molluscum contagiosum again in this child. So if you don't think about something, you will not diagnose it. If you don't keep this in mind, we will miss on the diagnosis. I, for one, I did not think of this man or this cervical lesion as AIDS lesion or toxoplasma. I thought of it as ependymoma or astrocytoma. And I've been taught, obviously I did not listen, that you could never diagnose on the MRI. Whenever you say something, it turns out to be something else. So you speak about pathology, you put a differential diagnosis, but you can never, ever be sure of the diagnosis beforehand. Just keep your eyes open, and this is just one example. I would ask Dr. Muntasir to come back again. I want to ask him a few questions. So I'll give you the microphone if you stand there.
Yes.
Stand there, please.
I have a question. Don't you usually, I thought foreign people that come into the country, we usually screen them for HIV.
This is one of the questions I'm going to ask.
This
well,
is the
this
routine
is-
that we had in our hospital.
Yeah, this is a question. Should we be doing HIV for every patient coming from outside Jordan?
I think there are, the short answer is yes. There are countries with higher HIV incidence regionally and globally. You'd have to say countries which have had wars, such as Libya, Yemen, Iraq, do have a higher HIV prevalence than we do. From my perspective, any patient that's undergoing an invasive procedure should be checked for HIV, hepatitis B and C.
Yes.
I
I agree.
Thank you.
Okay, what's the incubation period? Suppose somebody had
HIV?
HIV.
It's variable. It's from the time, incubation period implies that from the time of catching an infection to the time that it's clinically manifest. And it may be up to 10 years
Up to 10 years. Yes.
to be clinically manifest, although the virus starts replicating almost immediately. In a couple of days, you'll have a high viral load in the hundreds of thousands.
I have a story to tell here. I was in London training in the Yatkin Samola Hospital in London, St. George's Hospital, and I had a patient with subarachnoid hemorrhage, anterior communicating artery aneurysm, and my boss asked me to do the surgery, which was a privilege. So I went and spoke to the guy. As I was speaking to him, another guy came in, and they started kissing and cuddling. So it was strange for a Jordanian like me to see two males kissing and cuddling, but I got the gist of it. And I said, you have an aneurysm, we need to operate upon you, and we need to prepare for units of blood. He said, I am Jehovah's Witness, no blood transfusion. So I went back to my boss, what should I do? He said, well, if he's Jehovah's Witness, you cannot give him blood transfusion. You have to go and clear the aneurysm without blood. So I did. I just mentioning it as referral to the infection, the incubation period. And we did the clipping, he was discharged, but I live in nightmare for so many months and years that followed, fearing that some way I contracted the disease. So if you don't contract it because you got the contact, be aware that you may contact it 10 years later.
Yes.
Okay, some other questions. Can we
Can I first comment on
Yes.
that? In fact, recent developments in the treatments for HIV
Have made the situation where you might be exposed, right? Stick yourself in surgery from someone who's HIV positive. First of all, because of the treatments, that person, if they are on treatment, they might have an HIV load of 0. So that's, or even the lower the HIV load, obviously the less contagious the patient. Number 2, if you do get exposed, we now have the ability to give post-exposure prophylaxis with very effective anti-HIV medications, combination, 3 drugs for a month that typically prevent the HIV virus from establishing itself in one's lymphatic system. The sooner the better. We have a 2-hour window after exposure that we need to give treatment within.
Okay, suppose that I'm HIV, you know me, I'm HIV positive,
Yes.
and I come and want to shake hands with you. Would you shake hands with me?
Yes.
There's no fear of shaking hands
No.
with an HIV patient.
I'll kiss you on the cheek.
Kiss
But
and
don't
cheek.
push it, Ibrahim. I'm not kissing you on the lips.
So it is the kiss on the mouth where saliva would be transmitted
Yes.
is the danger. But shaking hands or kissing on the cheek does not transmit the disease.
Absolutely.
And I remember when I was in England, Princess of Wales, Diana. She went to, I can't remember the hospital, she went to an IDS patient, and in front of the cameras she shook hands and she kissed him on the cheek, saying that there's no danger from that.
And that was in the 80s, way before
Absolutely.
we understood.
Let's continue the questions and then we'll take the questions from the audience. We will. HIV test without patient permission. So you suspected me as having
Yes.
disease. Can you ask for HIV whether inpatient or outpatient without my permission?
Yes, and that's different according to each country's laws. In the United States, we had to get a signed permission before we test someone. In Jordan, we don't have that as a regulation as yet. I wish Dr. Mu'min was here so he can comment on this. But I
We
typically-
actually discussed this
Kanun
point.
did, we should.
Okay. So someone from the audience is saying the new law mandates that we ask permission. And typically this is never a tough area. If you present it to the patient as we just want to test it, it's a routine test just like any other test, and it's important for your health, I don't think most patients would mind.
The next question, you diagnose a case of HIV positive. What is the medical legal sequences of not reporting it?
Good question.
You should report it, yes?
Yes, of
Now,
course.
in Jordan, the way it is set up, the screening test, which looks for antibodies, and typically must be confirmed with Western blot, which looks for HIV antigens. Now, that second test is done in the Ministry of Health. So any lab would have to send the patient's blood for testing and confirmation at the Ministry of Health, where they would know about the patient.
We're talking about Bashir Hospital here.
Yes, the central labs of the
It's not at
Ministry
Bashir, actually.
of Health. The central
It's
labs.
the central lab.
All right.
And the thing of it is, they expect us as physicians to report our patients to the Ministry of Health. And it becomes an issue sometimes because even now, by law, these patients cannot re-enter Jordan. If they're HIV positive and known to be so, they'll be stopped at the airport. And I sadly remember a guy who was a Yemeni patient who had HIV. His mother sold the house to come and get treatment in Jordan. And then when he would come back for a checkup, they wouldn't let him in at the airport. I think this is archaic. We should do away with it. There's absolutely no danger from any HIV patient once we get him into the healthcare system.
How
It's
many-
downright criminal.
I have to agree with that.
How many-
We're stigmatizing patients, we're preventing them entering into the country. It's downright criminal, which actually
I agree.
leads to the fact of the permission. Some patients, few patients who actually know this info, would actually refuse the permission to the test. So either the test is being done without their permission, which is criminal, or it's being done and then they get stigmatized for having disease, which is even a much more heinous.
So you cannot win. How many cases have you seen every year, per year?
I've probably seen about 4 to 5 per year.
So
in
how
the
many
private
cases in Jordan have been
sector,
diagnosed with?
we don't see all of them.
Sure.
There was a report from the University of Jordan by Dr. Faris al-Bakri, and he had the Ministry of Health had collected 300 cases. But I can assure you, if you multiply that by 10, be closer to the reality.
Absolutely.
And some of them are not Jordanians, so they will not be included in that
Sure.
study.
Let's finish the questions with Dr. Muntasir. If this man, our patient, we diagnose them as HIV positive, which contacts you want to meet? His wife,
So we
his
want
kids,
to test the wife,
the kids?
any kids that are 10 years or younger. Now, if the wife is negative, then the chances of being transmitted to the wife and then to the kids through pregnancy is eliminated. It is rare, extremely rare, for that person to infect his children through casual contact. But we like to test the children.
But he can
obviously.
kiss them on the mouth.
Even so, that rarely, if ever,
Yeah, that's a
transmits
controversial
HIV.
thing as far as
Yeah. The thing of it is, you had questioned, and I have to commend you for doing that. Now, if we would know his sexual contacts,
Yes.
we definitely want to follow up with those individuals.
Provided that you have his permission to doing that.
Yes.
Right.
And there's a very big problem when the patient, particularly here,
Yes.
would deny you that permission. And I'm really worried about his wife
Yes.
or his significant other, etc.
I have had patients, I'll say they were not Jordanians, they were from the Gulf area, where that we tell the wife. We told her anyway.
So,
Okay. A few words for the nurses, the doctors, and lab staff. What should they do to avoid this
Yes.
disease?
All of us healthcare workers should consider everyone contagious.
Yes.
That's the best way.
Everyone.
Everyone. And the standard of precautions is if you're in contact with body fluids, you should be wearing gloves. And after you remove the gloves, you wash your hands or use alcohol gel. So any procedure that may expose you to the patient's fluids should always be done with gloves on. The only fluid that doesn't transmit HIV that much is urine, but that's not relevant.
Just a point is that
Sure.
بس مشان تحكي لهم قديش what is the lifespan of the virus outside the mouth.
Yes, the virus does not live that long on surfaces, a few hours. It's a weak virus. Remember when this came out, it came out in men who had sex with men, and that's a very rough procedure that transmits. There's bleeding, etc., etc. So one would be unlikely to catch it from a surface.
I can't emphasize this enough because what happens, what you're asking for is standard body fluid precautions which should apply to any patient in front of you. But what actually is happening in hospitals in this country, including really big institutions in the private and the public sector, when patient gets diagnosed with HIV, he is like a recluse in the hospital,
Yes.
and nobody is touching him, including very big shot ID docs and administrators who prevented the sample from being run, the blood sample from being run in the standard CBC machines for reasons that are just beyond my comprehension. I have seen this with my own eyes.
Muntasir, thank you very much.
Yes.
I'll take the
But if I may just comment
Sure,
quickly.
sure.
Obviously, that's very objectionable. And if our patients don't find compassion from us, where are they going to get
Thank
it
you.
from?
Yeah.
The second point, be quick, because you mentioned the mothers, and this is Farah, obviously. Now, treating the mother will reduce the risk of transmission to the baby. But we know that a large percentage of transmission happens at the time of delivery.
And so if you catch a patient, any patient that comes, every pregnant patient should be tested for HIV. But if you have someone that comes in late at night, not known to you before, test them for HIV. If they're positive, you can give them treatment intrapartum and prevent the transmission by half.
Cool.
Maurice, you wanted to ask?
Yeah, I wanted to actually.
Please. Come over.
No, I mean, what I wanted to ask is this. This patient obviously had an 18 months history, and obviously he'd been missed along the way. He's had this MRI, and obviously they haven't diagnosed him. Now, what I wanted to ask you is this. Did he need the surgery if we knew that this was toxo? I mean, would that lesion in the spine be
Amenable to medical-
will it amenable to medical treatment?
I will answer this.
Okay,
Huh?
thank you.
If the patient neurological condition is deteriorating, as in this patient, he has quadriparesis, you should go in to take as much of the lesion as possible. But if not, if he's not deteriorating, then you diagnose HIV positive, then you can stop there without surgery. Unfortunately.
I actually have two comments since we are in our hospital in pediatrics. The first comment, we reported the first cases of small muscle tumors in HIV infected kids, patients in JAMA in 1991. It was an association of Texas Children's Hospital and Chicago University, and there is an increased risk of leiomyoma and leiomyosarcoma in patients, HIV infected kids, and this was in JAMA. The second important point that was not mentioned at all is how to test for HIV. We have 3 tests available for HIV. The first one that is the earliest to detect is by B24 antigen, which is the earliest to detect, and by 1 month we detect about 90 to 95% of these patients. Then comes the PCR, which is about the 3 months, it detects about 99, from 2 months to 3 months we have the PCR. Then we have the ELISA test for HIV antibodies, which from 3 months to 6 months it takes about 95%. For the first one is B24, which is a capsule, an antigen capsule of the HIV.
Morning. So what's a humble oncologist doing in a toxo session? I have to emphasize a few things. One, as was the HIV part was beautifully, and toxo part was beautifully elaborated upon by Dr. Montasser. I have to emphasize that you can see toxo in the brain and in the CNS in HIV negative individuals with all these risk factors. And I cannot emphasize enough how easy it is to miss that. And I usually say the anecdote with a patient who had a past history of Hodgkin's lymphoma, of which he was cured, and a past history of prostate cancer, also of which he was cured, and presented with a brain lesion. And he was elderly, he was 75, his performance status was 2. And the plan of the oncologist then is that this looks like GBM or looks like metastases, send him for radiotherapy and call it a day. And had it not been for my emphasis upon diagnosing this with a biopsy before, the patient who had 2 cancers before and was labeled with a 3rd one, or with the possibility of MET, despite the fact that prostate and Hodgkin's do not usually involve the brain, and he would have been killed by the radiotherapy he would have received. That patient had toxo and he was HIV negative. And he died of gram-negative sepsis 2 years later, which is completely unrelated to any of this. But what really looks like that is actually a lot of things. Ependymoma, astrocytoma, subependymoma, these are real cases that would really look exactly like this. And the importance of that is in the ependymoma after surgery and radiotherapy, the treatment of choice is platinum-based. Astrocytoma after surgery and radiotherapy, it's observational. It's a high-grade glioma where we would give an alkylator or nitrosourea. Epidermoid lipoma can present in a pattern like this. But things that I want to emphasize, tuberculoma, with all the discussion about TB, we are living in an endemic country and an endemic zone, and it's frequently missed. MS, and I'm not going to comment further upon this because they can really masquerade as that. And absolutely, absolutely, when you have such large, and these are actual cases. So it would, they can be HIV positive, they can be HIV negative. And last thing, because these patients a lot of times are getting labeled on radiological appearances or presentation appearances, and they're being sent to radiotherapy without actually having a tissue diagnosis. The anecdote to which I alluded in introducing my part of the talk is an actual case where a patient would have been killed, and indeed this patient would have been killed, with radiotherapy missing the actual offending infectious agents that can be treated basically with sulfur, for God's sake. Okay.
عندما كنت تعرض حالتك دكتور إبراهيم كنت أن أقاطعك وأقول ماذا عن العين، أنك لم تذكر شيئا عن العين يعني. وعندما تكلم الدكتور منتصر أعطى شرحا وافيا. أذكر أننا قبل 35 عاما كنا نجد كثيرا من حالات التوكسوبلازموزيس في العين كحالة مفردة في منطقة الماكولة وحالة قديمة، ولا في أحيانا كنا نشوف رياكتيفيشن في مناطق أخرى. بالنسبة ل HIV من خبرتي عندما كنت في العراق أتاني مريض ولديه كرونيك يوفيايتس وبعدين ريكارنت يوفيايتس. عملت له كل الاستقصاءات المخبرية. بعدين فكرت قال لي دكتور اعملي اللي بدك إياه، اعملي لي فحصيني. بعد عملت HIV دون أن أذكر له ذلك. ذهب إلى المختبر فتبرع أحد الأشخاص منه، قالوا شوف الدكتورة شو عملت لك؟ عملت لك الفحص هذا. فأتى المريض بعد أسبوع، طبعا لديه نيجاتيف كان، ولكنه كان غضبان ثائر، وقال دكتورة أنا بصلي وبصوم، شلون تعملي لي هذا الفحص؟ فاعتذرت إليه وقلت له هذه مشكلة أنه في المختبر يعطى التشخيص. الحالة الثانية أتى لي مريض في نفس الحالة بعد أسبوع، ولديه في العينين اثنتين التهاب حاد ومتكرر في اليوفيانتس. فأنا كنت خايفة من الدرس الأول، ومعاه كان رجل كبير ومعاه شباب كبار أبنائه، فكنت متحرجة. عند ذلك طلبت من الأبناء يأتوني على حدة، وبكل صوت خافض قلت لهم أرجو أن أجري هذا التحليل لأبوكم. فضحكوا وقالوا دكتور إيش خايفة أنت؟ أبونا إبليس اعمل اللي بدك إياه. فمنذ ذلك الوقت يجب أن يحرص الإنسان
شكرا جزيلا.
عندما يعطي
I
المريض
must say
تحليل.
دكتورة سارة is one of the leaders in the Arab world لتعريب الطب. So she does not like us to speak in English. She likes us to speak in Arabic. But because we are speaking to international audience in the States and others, we are speaking in English. دكتور عماد، دكتور نخلي تصفي ماشي.
Toxoplasmosis is one of the elements of TORCH syndrome in newborns and small infants. Can we diagnose
Can you tell what is TORCH?
between toxoplasmosis and other elements like rubella or cytomegalic inclusion disease or herpes? Thank you.
دكتور عماد.
I'm not sure whether I missed it or not, but was an LP done with CSF analysis and cytology?
No. First of all, in tumors we don't do CSF analysis as a rule, because it is a known fact from the surgical point of view that if you stick a needle in the back of patients with the tumors, the tumor may sag and the patient's condition may get worse. So that was one reason we did not do the CSF studies. The other one, afterwards, we did not do it after we knew that he is HIV positive, is that CSF studies in toxoplasmosis is rarely helpful.
There was a comment from Dr. Ma'an Hadidi that there was a distal obstruction.
Yes.
Was that, I didn't see any further comments.
No, it was just a stone in the...
It was just okay.
Yeah. Any other questions, please?
Thank you, Dr. Ibrahim. My question is that your approach was going to be different if you knew from the very beginning that this patient has HIV?
Sure. We answered these questions that if I knew that he's HIV positive and his clinical condition was stable, he was not deteriorating, I would not do the surgery. I would just refer him for treatment. This patient had a quadriparesis of a grade 3/5 with some urine incontinence. So he was symptomatic, and you need to do it urgently to take as much of the lesion as you can and follow that with the treatment. Please.
Thank you, Dr. Ibrahim. If you know that your patient is HIV positive, your differential diagnosis will be toxoplasmosis and lymphoma only, or you can put also tumors?
Because even patients with HIV positive, they can have astrocytoma.
I know, but at the top of the differential diagnosis.
No, if in top, yes, I should think.
Lymphoma and toxo.
Yes. In HIV, I should think at the top of my list, which should be like, what are the diseases related to this? But I have to remember that brain lesions that we have seen, it could be glioma, it could be metastasis, it could be anything. But, one first comes first.
Well, indeed, the differential that we had discussed would have been little influenced by the HIV status, so positive or negative, the list of differentials summarized would actually still hold. emphasizing again, even in HIV-negative patients, and I cannot really emphasize this enough, and Dr. Montes would agree with me, we see toxo in them all the time, and the important thing of this is these are the patients are curable with sulfur. I just want to comment upon Dr. Sura's interjection here, and I am sure that Dr. Montes would agree with me. We want to take this opportunity to condemn in the strongest way possible the systematic stigmatization of HIV-positive patients in this country. The fact that they're being denied re-entry, the anecdotes that I've mentioned, and these are big hospitals, the one I'm alluding this, in the public and private sector, where patients are dealt with as if they are recluses in the hospital just because of HIV serologies. For the students of the audience, we are physicians. We're not here to pass judgment. Not to mention the fact that most HIV patients in this country have it because of blood transfusion before the screening era and because of the hemophiliacs. But be that as it may, we are physicians trying to help patients. We're not passing judgments. So the comments of Dr. Sura are very well taken because these are actual scenarios. And when this is replicated by the Ministry of Health, this is really criminal.
Sure. Okay. So,
how long does it take for the lesions to subside or to disappear on the MRI? I mean, if we suspect it to be a toxoplasmosis from the imaging, we started the patient on the therapy. How long does it take for the lesion to
clinical and radiological.
No, I'm asking about radiological.
Within 2 months.
2 months.
Yes,
that one you showed it was 6 months post.
Yes, sure. But it can take up to 2 months to.
So, and if you had started therapy empirically, you would look for clinical improvement. If you don't get it within 2 weeks, then you go to a brain biopsy.
I have to take the biopsy after 2 weeks.
On the clinical improvement, radiological takes long.
Any questions? If not, I have two things to comment on. Quick ones. I remember when I was training in England, we had a patient who had a head injury, and the resident took the history from her, etc., and from the people with her, and he took the file, went to the patient's bed, talked to her, and forgot to take the file away.
Ooh.
So she opened the file, and what did she read? This patient is a prostitute who was involved in a road traffic accident. She was a prostitute, a known hooker, to say the least. She was known in London area. So she sued the hospital, she sued the consultant in charge and the resident, and she won 1 million sterling. So don't leave the charts with the patients, don't leave the charts unattended to, because these are private information of the patient. Next week we'll have another very interesting case, again related to the spine, related to hematology. This is thalassemia patient, and you know thalassemia patients, they want hemopiesis. So this little girl developed extra hemopoietic centers in her vertebrae and ribs, and that caused spinal cord compression. So it's going to be interesting to discuss the thalassemia and the hemopiesis in these patients, and this very rare case of spinal cord compression by hemopietic tissue in thalassemia patients. We'll see you next week. Thank you very much.